deputising, Adam's deputising for Glenn, Sue's deputising for Sarah Collett, Phil Gilbert, Paramjit, Graham Nuttall, and Sue Whelan Tracy all send their apologies. Is there anybody else?
We've got 2 more apologies from Sharon Ellswood and Bernard Usselman.
Okay, lovely. Thank you very much. So then, do the formalities. Are there any declarations of interest? Okay, excellent stuff. So item 3 then, is everybody happy that the minutes of the last meeting of the 9th of May and the extraordinary meeting of the 19th of July are a fair and accurate reflection of the discussions that took place? Okay, we've got a thumbs from Roger, so it must be okay. So we'll move on then, and we're on to the minute actions. Let me see if I can get this to come up properly. Oh, hang on, bear with me. It's playing up. So we're on matters arising and actions. So just bear with me 1 second while I get this to work. So we have all actions, in fact, are complete. The elective hub, time-lapse photographs are on the website. The patient experience group, Sharon Ellsworth shared via email to the Council of Governors.
One from now, lots been down to.
Okay, sorry. Who's it? Patient Care Committee approved minutes. The point in that was raised at the PCC meeting held on the 13th of May, and the minutes corrected there. And the final one, which was the draft quality report, this says the trust objectives for 24-25 are available within the public board meeting papers on admin control. So if there are no other action points that people think are missed, then we'll move on to agenda item 6.3. Make sure that is the right agenda item. Item 6.1, which is government requested assurance. I'm not sure what is in that actually. 6.2 is the quarterly status report update. Sue, can you help me? It's not telling me.
So we've got item 5, if there's Vice Chair's remarks, and the update on the ICP. Okay,
very important. So I nearly forgot that. So I think to say that as an organisation, I think you all know this, that we are a striving organisation, trying very hard to deliver the best possible patient care, and at the same time challenge ourselves to balance the books. And we're in a, it's a tough place to be, but we're in the place that you would expect us to be. I think and some of the evidence of success, by the way, some of the national recognition we're getting. And recently we were recognised nationally as the best place for ED experience in the country, which I think is fabulous. But I think then if you look at the ICB is definitely challenged. And I think financially where we are is George Eliot and Swift are both driving forward to deliver their break-even plan. But UHCW are struggling, and the evidence is they're going to be some way adrift of plan. And that has ramifications potentially for the whole ICB. And I think Kim may touch on this a little bit when she does her financial numbers. We can't control what happens to UHCW, and however hard we strive in what we do, we won't compensate for them going significantly astray. So at the moment, our focus is on delivering what we must deliver. Elsewhere in the ICB, the Care Collaborative has started moving forward. Adam and I both attended the recent meeting of that, and actually that was quite encouraging because, as you know, that's a meeting of all the key stakeholders, driving towards the delivery of place. And the positive thing was, I think all the stakeholders there were definitely trying to do the right thing for the community that they serve, and there was very little parochialism or defence of their own bailiwick in that process. So I think that was quite encouraging. The only other thing I perhaps all to say, and I haven't any more at this stage to say about the ICB, but I'm sure it will come up as some of the presentations are made during the day. For everybody's benefit here, tomorrow is Charles Ashton's last board meeting as CMO. And Charles will be replaced by Bhaskar. I would like to tell you what Bhaskar's surname is, but I'm really struggle to pronounce his surname. It's Bhaskar Varadarajan, but we all know him as Bhaskar, and Bhaskar is a very good guy, so he's a very, very positive replacement for Charles. But Charles has been a voice of reason and good advice and sound comment for all the time I've been here and many years before that, and I think he'll be sadly missed around the board table. But the good news is that I think in the NHS, when you retire, it doesn't mean you disappear in your entirety. So we will have Charles and his sage advice with us for about 1 day a week for the foreseeable future. So that's good. So good luck to Charles in his half retirement, and good luck to Bhaskar as he takes over as CMO. So those are the VC's remarks, and then we will move on to the assurance items, item 6. And this is governance requested assurance. And the first piece, Sue, if there's nothing on 6.1, is the operational assurance quarterly status update report. And I think, Adam, is that you? Yes?
It is indeed, yes.
Thank you.
I will share my screen, but I will start first of all with an apology, because the paper that originally went out with the minutes was incorrect. So if I share my screen with the accurate paper, we will make sure you get it following the meeting, if you haven't already. And I'm going to take a quick whistle-stop tour through these, but I'm of course happy to take any questions at the end. So as you'll recall, at the roundtable last October, we had our session to think about our objectives for this year. We went through a process of refinement following, and we ended up setting a number of objectives aligned to our 4 big moves and to our strategic pillars. We will go through the same process this year, not to give too many spoilers away, but the roundtable planned for later this month will look at these objectives, some proposed objectives for next year, and we will ask for your input with anything missing, and to prioritise the long list of objectives we have for next year. But just to run through this year's objectives, so obviously we're halfway through the year, so these aren't by and large aren't complete yet, but I think it's fair to say there's good progress against all of them. If I start at the top, the first objective related to the trust's value as an inclusive employer. And while we know our staff survey results were one of the best in the country last year, one of the areas of particular focus that came out of them for us was the need to develop our inclusivity agenda, because we could see very clearly in those results that the experience of all of our staff was not the same. We've done some really good work on this year in the areas where we felt we needed to focus. So we've introduced an anti-discrimination toolkit and anti-discrimination help desk. We've also introduced cultural competency training and have established a neurodiversity staff network, and introduced the Oliver, or I think it was actually last year, we introduced the Oliver McGowan training, which again focused on patients with neurodiverse needs. So a lot of work going on in this area, and it clearly remains a focus for the organisation. The second objective relates to the use of technology to help our people do their jobs more effectively. And I guess there's 3 key areas of work here. One of the areas we've really focused on is how technology can help us do simple tasks more easily. So things like those who want to receive their letters electronically, ensuring that they can do so. And we've done quite a lot of work on that. We have also progressed our ambitions for a replacement electronic patient record system, and indeed signed our contract with Cerner a couple of weeks ago. Finally, as you'll be aware, we have a partnership with a technology company called SCC to look at technology innovations and how we can use them across our services. And we're refreshing our strategy for that as we speak. But if you watch ITV Central News tonight, you will hear a story about one of the particular technology initiatives we've introduced, which is the Lola chatbot in our wheelchair services, which has significantly reduced triage and waiting time. So, as I say, ITV Central News tonight, very well-timed news report on that particular initiative that we've introduced. The third objective relates to training, retaining and growing our workforce. And I think we're doing a lot of work in the background on this, led by our HR team. And I think what's really encouraging is our low turnover rate, so significantly lower than our peers and below our upper limits. We've really focused on reducing vacancies this year, and you'll also be aware we've had a significant reduction in our agency spend. So we're spending less than half of the amount on agency we were this time last year, and of course having more substantive staff in our workforce rather than temporary staff is both safer and leads to a higher quality service. And I think the other aspect of this is, of course, the staff survey results that I've already mentioned. The next set of objectives relate to our big move around Home First. The first relates to the implementation of the Community Integrator Service. So you will be aware that we were awarded the new out-of-hospital contract this year, which has been relabelled as Community Integrator. This relates to all of the previous out-of-hospital service, but also gives us some new responsibilities as a lead provider, including a number of commissioning arrangements relating to subcontracts in those services. Progress is continuing well. We only took on this contract, this new contract, a couple of months ago in June. So our teams are still working with the ICBs on the handover of those commissioning responsibilities, with the first new commissioning arrangement coming across to us in January, which is discharge to assess pathway for North Warwickshire and Rugby. So good work going on there. I think the second aspect of the Community Integrator contract was the integrated neighbourhood teams and neighbourhood level leadership for our community and out of hospital services. We're doing a lot of work with primary care on this. We have a joint partnership with primary care through our Strategic Innovation Board, and are looking at some specific pathways of care with primary care, and that is going quite well. The final objective in this section relates to the electronic patient record system for community teams and our plans there. And we have now completed that work with our children's community teams, moving on to our new Cerner EPR when we implement that, and the remainder of our out-of-hospital teams, keeping with the EMIS system, which is used by primary care. If I move on to prevention, the first of the objectives here relates to championing children and young people's services. It's been a real focus of our work this year. We've done a lot of work in maternity and paediatrics, as you know, and we've also done some really focused work with our health visiting services. And we will be doing more in that area for the next 6 months of the year. The next objective relates to the other end of the age spectrum, which is our frailty services. And this is really an area of strength for us. We've done particular work with West Midlands Ambulance Service, our community teams, and our emergency department to prevent admissions, to ensure more rapid discharge of patients in this group. And we currently have some work going on with care homes. So lots of work going on there. And the final objective in this area is about prevention and applying a prevention lens to all our projects. And I think this is particularly important in light of what we've seen in the Darzi report, which I'll talk about in the confidential section later, but also what we know the Secretary of State has said is the big shifts for the NHS, one of which being the move from treatment to prevention. I'm really pleased now that for all of our business cases and all of our planning initiatives, we are applying a prevention lens as well as a treatment lens. So we're looking at how any development can support and develop our prevention agenda. We are also about to introduce a new prioritisation framework for new developments and changes, which includes prevention as a scoring factor effectively. So more of that in the months to come. The final of the big moves relates to carbon reduction. So anyone who's visited the Warwick site lately will know there's an awful lot of building work going on, some of which is about the new front door, but some of which is related to the SALEX funding we got, the air source heat pumps and so forth. And that work to decarbonise the site is well underway now. In fact, they're almost complete at Warwick, and we'll be moving to our other sites in the coming months. The second of the objectives in this area relates to small behavioural changes to support our green plan. So our green plan is in its final year and will be refreshed next year. And as part of that, we're really working on the KPIs that support these smaller changes. I think there's more work to do in this area, and certainly we're working with partners to do it. But it is really an area of interest for our staff, and our staff are very engaged in this behavioural working agenda. I think the areas where we have more to do are particularly around transport to our sites, and some of our work on procurement and so forth. Finally, in this area, there's an objective around working with our partners, and indeed the ICB is currently developing a climate adaptation plan, and we are a key part of that group. Moving on to the enabling objectives, if you like. So these are the objectives related to our strategic pillars. The first relates to productivity and the work we're doing around productivity. Now, I'm not going to say too much about this because Kim is talking about it later on the agenda. But clearly this has been a real focus of our work this year. And we are looking at productivity across our services. We know we're already one of the most productive organisations in the NHS. We're one of the few organisations that's in fact seen a productivity increase in the last few years, but that doesn't mean there's not more we can do. And as I say, Kim will talk a bit more about that later. The next of these relates to the development of the second phase of our elective hubs. So first phase is obviously what we're building with the new front door. The second phase replaces our day surgery theatres. Our board approved the strategic outline case for that last month, and we're now going into the detail, so the development of the business case and the financial model and so forth. So that work is coming along. The next objective relates to the Excel in Everything programme. So again, this is a key part of our productivity plan. It obviously brings together productivity, operational delivery, and quality, and is leading the delivery of our cost and productivity improvement programme this year, for which we have a £20 million target. Work is going really well. I think Excel in Everything has delivered not only on our cost improvement plans, but some really focused quality work. So particularly if we look in the areas of outpatient experience, theatre productivity, and so forth, we've seen some really good results. And I think the sort of led from the ground up approach of the Excel in Everything programme has gone down really well across the organisation, and certainly well done to our teams for latching onto that and really delivering. Objective 16 relates to quality of care. So this is about maintaining our CQC rating, ensuring quality is at the heart of everything we do, led very clearly by Fiona. And we're currently going through a process of reviewing the new CQC key lines of inquiry against the work we're doing across the organisation, and assuring ourselves that we meet those. So that work is well underway. In terms of research, we have realised our research strategy milestones. I think there is we are looking at a refresh of our research plans for next year, led by our ACMO, David Adalami, but certainly in the area of clinical trials, certainly in the area of digital innovation, there's some great work going on around research in the organisation. Our final objective on here is about capacity and demand modelling effectively. And this is particularly important given what we know is a significant increase in demand that we've seen over the last few years. We have done a really detailed piece of analysis. We've got some supportive work going on across the group to make sure we're all using the same methodology, and the outcome of this work will be presented at a board workshop, the first board workshop of which actually later this week. So some really good work going on in this area, and I think we will share some of that capacity and demand modelling work with governors, if not at the next roundtable, then at a future one. So lots of good work going on. I think it's fair to say we're pretty much on track with all of our objectives this year, given we're halfway through the year, and I think these are really helping support where we are as an organisation. I think the other thing that's really assuring is our objectives and our big moves at a higher level really fit what we're hearing nationally in terms of the direction and priorities of the NHS. Happy to take any questions.
Adam, thank you very much. So questions and perspectives to Adam. Roger, you were first in.
Thank you. One, whilst I support entirely the idea of digital support and enhancing what can be done digitally, I think it behoves us all to remember that there is quite a large cohort of people who cannot access services or digitally, either through age and lack of learning, or quite simply without the financial resources to access this. So I think we have to make sure that there is a twin track to allow people to get the same services without digital, although digital should be the preferred way.
I think you're absolutely right, Roger, and I think our approach is for those who want and expect a digital route to access our services, we should provide that, but that shouldn't replace or take away from the other routes of accessing our services, and we need to put as much focus on those.
Okay, Roger, thank you very much. Thank you, Adam. Callie.
Yes, thanks, Simon. I just, because everything changed in short time, and I read the one-page report that you initially did, I don't know if they'll be addressed later. It all has to do, my questions all have to do with workforce. And I just wanted to understand more about flexible working, leadership programs, and the widening access participation. I don't know if these are covered later on in this meeting, but these were some of my questions about what it all comes down to, because obviously, like leadership programs, do they apply to what groups of staff, what grades, etc., etc. Flexible working, how do you deal with that when it comes to meeting business needs as well? Because it all obviously needs a lot of planning. So just these are my questions really about workforce.
Okay, so split them in two, Callie. So let's talk about leadership and then talk about flexible working, Adam, if you could.
Yeah, absolutely. And Callie, I'm really conscious we've not got an HR and workforce rep here. So I'll give a very high level response, but if you want a bit more detail, then I can ask Nick Rees to speak to you about that. So I think in terms of leadership training, I'm going to refer back to the Darzi report again, which, as I say, I will talk about later. But one of the key messages in that was that the NHS hadn't invested enough over the last 10 years in developing its leaders to deal with some of the challenges that we are now facing day to day. And I think as a group, we've recognised that. And rather than go it alone as organisations, we've looked at how, as 4 trusts, we can build a leadership and development programme that really meets our specific needs. So we've put in place a group-wide programme for general managers and other senior leaders that really introduces them in a kind of workshop format, a structured programme to some of those challenges, and we have experts in various fields come and talk. On top of that, we have access to the other NHS leadership programmes, so the Mary Seacole leadership course, for example, which are open to all in appropriate roles to access that. So we have quite a well-developed leadership program, I think, which is constantly evolving, and I think will continue to evolve over the coming years as we see what comes out of the new NHS 10-year plan. If I talk a bit more about flexible working, then flexible working is a more complex area, because flexible working means lots of different things, and I think people often make the mistake of thinking it means just flexible hours, but actually it's a variety of initiatives, and we strongly believe as an employer that the way to attract and maintain the best staff is to provide a flexible way for them working with us. So, for example, one of the initiatives we've trialled in the last year is the ability for staff to self-rota, so pick the shifts that they would like to work, and we've had some really good feedback on that. We also know we have a challenge with parking on our site, so giving staff the opportunity to work at home when they're able to do so in their job has been really helpful in managing that. It's clearly something we need to monitor and review, and I think what we see in terms of productivity is evidence of the fact it's working and that our staff like it, and it's helping to retain our workforce.
Right. Sorry, just two things, and I don't want to be a stickler, but it has to do with spelling in the report regarding fibromyalgia and colorectal cancer in your report. Sorry, that's all. If you have a look at the report, that's all.
We will correct that, Callie. Thank you.
Thank you.
Callie. Okay, so finally on this section then, David G.
Thank you. In your report, you mentioned the carbon and green programs, but do you also put the lens on the programs regarding financial cost? In other words, is it an advantage, financial advantage or disadvantage?
We absolutely do. I mean, any business case we do at the moment comes down to money, as you know, David. We've been really lucky with a lot of our green programme that we have funded it through the National SALEX grants. So the majority of the upfront costs have been funded externally via grant. But having said that, we know that the green programme and the new stuff that we're installing as a result of that uses electricity and not gas, and electricity is currently more expensive than gas. So we had quite a detailed conversation at board about what that means and how we manage that, whether we should do it, what the likely future direction was going to be. We shifted some of our investments so that we were spending more money on solar paneling to mitigate some of that effect. But there does come down that discussion and balance about what is the right thing to do now and what is the right thing to do for the future. But certainly finance is a key factor in that discussion.
Okay, thank you, Adam. Thank you, David. So, okay, moving on then. Thank you very much. We move on to 6.2, which is, sorry, 6.3, which is the patient experience assurance report. And Fiona. Morning, Fiona.
Morning. So similar to Adam, I'll just give a high-level overview of the report, but happy to take any questions afterwards. The report demonstrates that we have a fairly low number of formal complaints, which we have had for many months and years, and that remains consistent. Although we have a low number, we're not complacent. We know that we don't get it right for every patient. So there's some commentary in the report about the improvement work that we've done related to specific complaints and the themes of those, but also more generically the improvement work that we've done over the quarter. Particularly the focus over the last quarter has been on improving the response rates and the timeliness of response to those complaints. I think with the pressures within the organisation that Adam's alluded to, time set aside to formally investigate and respond to complaints has been a pinch point really for some of the divisional teams, but we've put some concerted effort into that, and I'm glad to say that there is improvement in that in those timescales. We've also increased the availability of interpreter devices based on they weren't always easy to obtain when they need them urgently, and we've also improved our bereavement and mortuary service pathway in terms of viewing of deceased patients and that support that we give to bereaved relatives. In the report, there's two things that I want to pull out in terms of what we're really proud of. And Adam, you stole my thunder, but we were third in the country in a recent CQC inpatient survey, which is an annual survey that the CQC administer for us. It's anonymous, but they write to the patients that have recently been inpatients. And so we're very proud that our patients are telling the CQC that they've had a very good patient experience whilst being in our services. We've had a heads up that our maternity CQC survey and our A&E CQC survey are both, the results at the moment are embargoed, but they look very positive as well. So we will share those with you when we can do. And finally, at the end of my report is the annual report for volunteers. And I'm hoping that everybody on the call has been able to read that, because it really does demonstrate how amazing our volunteer team is. 670 volunteers are part of our team at Swift, giving 47,500 hours of their time to support patient experience and staff experience actually across our organisation, both in the acute hospitals and in the community. A vast amount of voluntary time and effort. And I would take this platform really as to encourage the public to continue that work, and also join us as a volunteer if you wish. I know that our volunteers get a lot out of it, as well as our patients do. And we have got plans to grow that team this year. Adam's just alluded to one of our objectives this year is around growing our staff and volunteers as part of that. We have a draft volunteer strategy which will be going through our governance arrangement shortly, and we are starting to scope different volunteer roles that would further strengthen that volunteer team. So happy to take any questions, but they were the headlines for what I wanted to talk about today.
Yeah, thank you very much, and I do endorse what you say about volunteers and how important they are to what we do. So in terms of questions and perspectives, Roger, I think you were first up with your hand.
Thank you, Fiona. I did notice that both Greville and Thomas wards were missing from the list of complaints. Having been in Thomas ward in July, the answer was no complaint at all. But it would be interesting to see how others have responded in that ward.
Okay. To be honest with you, Roger, I don't know whether they're missing because they haven't had any complaints, but I will double check.
Thank you.
Thank you, Fiona. Ruth.
Fiona, I'd just like to ask if we are continuing to encourage young people, school children from youth organisations to volunteer, and also to encourage work experience for young people.
Yes, we're doing both. So in the volunteers report, there's a section called Kissing It Better, and that's the charity that we work with that supports the school children to come in and play music, or the health and care students to come and paint nails or do head massages or shoulder massages, or just sit and talk to our patients as part of their development, their education and experience. So that's generally facilitated through that. We do have plans to create a youth forum for our paediatric ward, and that's just in the planning stage, but that will be asking for patients or people that have had young people that have had experience in health to support us with that patient experience within our paediatric areas. Work experience, yes, we do still encourage work experience. It did drop off as part of the COVID pandemic, but we have started it back up again. Off the top of my head, I don't know numbers, Ruth, but I can ask Nick to send those through to you. That would sit within his portfolio.
Because it was interesting that several young people that wanted to do medicine had difficulty in trying to shadow people in the NHS.
Okay. Yeah. Okay. Well, I do know that we recruit people onto our bank that work as CSWs. So there's a good cohort of those that are wanting to go into medicine, and that's why they do it. But work experience, I haven't got the figures on here at the moment, so I will ask Nick to clarify that maybe in a future report. Thanks, Ruth.
Ruth, thank you very much. I just noticed Ollie said that recently we had 16 let me get the chat right, 16 volunteers under 18 as of the 7th of September, 16 volunteers under 18. David G. Yeah, David.
Yes, thank you.
Brilliant.
Several months ago, I applied to become a member of the Patient Forum as well as being a governor. Nearly 3 months later, I still haven't managed to get through all the paperwork. I'm still not an official member. The chair of the Patient Forum's comment was, it's so bad it's putting people off applying. Please, would you look into this?
I will do. Thanks, David.
Thank you for raising that, David. Okay, let's press on because we're starting to slip a little behind time, and we move on to David Spraggett, item 6.4, which is the Clinical Governance Assurance Report. Morning, David.
Yeah, thank you. The papers include April, May and June's meeting board reports, my board reports. And essentially they just show that the committee remains significantly assured about the clinical quality and governance at the trust. I think if people want to ask me any specific questions about that, then by all means go ahead. But I don't wish to add anything else to the papers.
David, thank you very much. Any questions or observations for David? Right, okay, thank you, David. Let's move on again then to 6.5 and Kim with the Financial Assurance Report. Oh, sorry, Mary. Sorry, before we go to Kim, Mary. You're on mute. Yeah.
Yes, it was regarding the clinical governance report going back to April, actually, but it's something I don't understand. Dave, you mentioned under the Haematology Summit, the beetroot risk stratification system. What is a beetroot risk classification?
Oh, I was hoping you wouldn't ask me that. It's an acronym, as you well know, and if for the life of me I can't remember what all the letters stand for, and if somebody else knows, please help me out. But it's essentially it's a way of that's used actually in haematology of assessing disease progress, really.
Okay, and do we know why the consultant didn't take up the post? Was it personal reasons, or was it?
It was personal reasons. It was personal reasons. Yeah.
Okay. Thank you.
It wasn't because he didn't fancy the working at the trust, because he had done some work at the trust, but he's got personal reasons.
Okay.
Okay, Mary, thank you. Callie, and then we'll move on to Kim. Callie.
Right. Yes, David. I just wonder if I know it's 3 monthly clinical governance committee meetings, but are there any reports regarding cancer apart from the screening? Do you get any reports from?
Oh yes,
because I couldn't see any reports regarding cancer.
Right,
whatever.
Callie, these are simply very abridged reports that I'm giving to the board. There's quite comprehensive minutes about the meetings, and actually we do get very comprehensive data regarding cancer activity, and not every month, but certainly it's a hot topic.
Okay, so you do get them, right?
Yes, we do. Yes.
Okay,
and those will all be visible, Callie, in the papers that go into the board packs.
Okay, thank you.
Okay, right. Thank you, Callie. Thank you, Mary. Mary, is that your hand up again, or you not taking it?
It is actually, if that's all right, Simon. It was about the cardiology. I was very concerned to see the waiting times in cardiology, and it wasn't picked up as a concern, which surprised me. This action to talk to GPs about diagnostics. This is back in May. Has there been any improvement in cardiology or working with GPs?
Yeah, the answer is yes. There's a lot of work going on in the background regarding that. Are you going to be answering that one as well, Adam? I don't know. But there's a lot of work going on in the background there. The important thing to note, though, these are the long waiters are not people with necessarily they're not urgent cases, because those are dealt with through the rapid access system. But the cardiologists are struggling because, of course, it's more staff. We have actually got more staff, I think. Is that right, Adam? We've appointed another consultant, haven't we?
Yes, that's what I was going to say. We had a number of vacancies, but we've recently been successful in recruiting, and I believe they're starting very soon if they haven't already.
Yeah.
Okay.
And sorry, can I just clarify for Mary the thing about with GPs, it's more to do with being clever and using technology to do some of the diagnostics to filter out those people that don't necessarily need consultant input. So actually it's a move in the right direction from what Adam was mentioning right at the beginning, that we want to move more to the preventative and the out of hospital.
Yeah.
Okay, David, thank you very much indeed. So we'll move on now to Kim and the finance report.
Thank you, Chair. So most people will be aware that the finances nationally are very challenging, and it's very challenging across the NHS. We've had a very difficult planning round which dragged on for a long time, but if I could just refresh your memories, I'm very conscious that we've, it's been a little while since we last met. So we set a number of different plans, and in the end we did submit a break-even plan at a point in time, which is our statutory duty. But that plan within an overarching system plan, which was a £27 million deficit, was not accepted. And we were asked to improve our position in order to ensure that overall the system submitted a reduced deficit plan, which was actually £20 million deficit at that point in time. So we rejigged our plan and we've set a surplus plan of £1.3 million, which is a stretch for the organisation. Nationally, there is still discussions going on about how they can give non-recurrent support to systems to actually reduce that deficit, and those discussions are still ongoing. So at a later date, I'm sure we'll be able to give you a further update in terms of what that means for us as a system. Having said that, as a system, we're already off plan in terms of where we are. For the month 4 position, we're reporting a £3.5 million deficit against a revised plan of a £2.7 million deficit for the month 4 period to date. we have got a bit of a variance against that deficit plan of about £785,000. Majority of that was driven really predominantly by the cost of industrial action that we experienced back in June. We now have confirmation that we will be getting a share of funding for that. That's been given nationally, and we're expecting to receive just under £500,000 towards that. So that's a positive situation, and obviously we've now heard that the junior doctors have accepted the pay deal. So there's no further risk of industrial action from that with the staff, which is positive. In terms of the challenge ahead, we are expecting our position to improve. As you know, we've completed a significant transaction, which will improve our position as we move forward. But there does remain a challenge really as we head towards winter. It is a balance between money and safety and operational pressures, and it's very busy, as you know, in the hospital. And we have opened extra capacity in order to ensure that our patients are safe. So it is a balance, and I think the Excel in Everything programme is a testament of how we work as an organisation to ensure that we get that balance, as right as we possibly can do. In terms of the remaining of the year, we have, as you know, got a significant challenging cost improvement programme of £20 million, but we have identified about £18.2 million of schemes. And some of that is obviously slipped, but we're pushing on really to ensure that we actually deliver in the second half of the year to ensure that we do meet our financial plan. I'm not, it is a challenge, but we're doing everything that we possibly can as an organisation to balance the books while maintaining safety for our patients. In terms of productivity, I have got a quite detailed productivity piece that I'm going to talk through in the confidential section later, and we'll also bring a more summarised version update for the next Council of Governors in the public domain to show really what we're doing around productivity. We've been doing a lot of work in terms of understanding, in terms of what services, offer a bit more contribution. And obviously that work dovetails into the productivity work as well. In terms of, Adam's already mentioned the excellent work that the organisation done in terms of reducing the agency spend. So that's been really positive, but there's still work to be done around reducing our spend on temporary labour and making sure, obviously, that we look after our staff in order to reduce sickness levels as well. The other thing I wanted to draw attention to is capital. We've got a large capital programme this year. It is challenging because we have to work within our systems partners in order to live within what they call the CDAL limit, which is effectively a limit on what we can spend on capital within the system. So we obviously have to work within the system to ensure that we deliver our capital programme, but also live within the capital limit that's set nationally for us, and that is can be a negotiation, but also a challenge as well. So that's being worked through at the moment and being managed. I think those are the key things I wanted to highlight for the Council of Governors.
Thank you very much indeed. So, any questions or perspectives for Kim? So, Kim, since nobody wants to ask you a question, I will. So, how confident are we looking towards the year end that we will hit our numbers at the year end?
I think we've obviously traditionally had a really good track record of delivering, but but it is more difficult this year. The context is really challenged. We've had flat cash effectively, so that is a challenge for the organisation. But at this point in time, we're obviously doing everything that we can to ensure that we do deliver the financial plan. That is the expectation nationally, and we're working with the divisions to ensure that we do that. But obviously, the balancing the money with the safety of the patients is the challenge. and we work very much together as an executive team in order to ensure that we get that balance right. But at this point in time, I would say that that there are risks to delivery, but we're doing everything that we can to ensure that we do to try and deliver the plan.
Okay, thank you very much, Kim. So let's move on then to item 6.6, which is the audit assurance report. So I think this is Oliver, is it? I don't think Robert's with us today.
Yeah. Thank you, Simon. So I'll be brief. I'll take these mainly as read. Unless anyone's got any questions, just cover a few points. As per David's, they cover April, May and June. Key things to note: we did a self-assessment in April, which was useful, although there was a low response rate driven by some IT issues. Nonetheless, we're doing some work on ways of working to ensure that we remain as effective as possible. We had significant assurance through the head of internal audit opinion throughout the year. We finalised and submitted the annual report and accounts on time, and we had no significant concerns raised by external audit. And we noted good work carried out in a number of areas, including contract management process, third-party contracts, and single tender waiver management, which showed significant reductions since 2020. And as per your introductions, Simon, I'm now handing over to Robert to lead the audit committee going forward. So happy to take any questions, but that's all I wanted to say.
Thank you, Oliver. That's great. So Mike Flaxman.
Thank you, Chair. I noticed on page 11 of the audit report that we've made 7 changes to processes as a result of reviewing compliance with the HFMA audit handbook. Could governors have a note of those 7 items of change so that we can understand what's happened? It will help me quite a lot with the procurement issues as well, if I understand what we've changed as a result of reviewing the handbook. Thanks.
Well, of course, yeah, there will already be in the minutes of the 12th of June meeting, I think, but we can make sure that you get a note of them as well.
12th of June. I'll try and find that then. Okay.
But we'll make sure you're circulating with them independently, Mike, and Oliver will pick that up. Thank you. Okay, let's move on then. Well, don't put your microphone off, Mike, because we're still with you. So a piece on external audit re-procurement update.
Yeah, Roger and I attended the scoping meeting, which was attended by people representing all 4 of the trusts. Ruth Allen chaired it. She's running this joint procurement of the external audit contract. I circulated my email that I sent to Ruth after the meeting, setting out what I think, because I think it's important to protect governors' interests in this, because as everyone will know, governors appoint the external auditors. We have a rather different system to everybody else, and we've got Swift CS in our consolidated accounts to make sure that's covered as well. I've got some doubts personally that there'll be much to gain financially from having a joint contract with all 4 trusts. All the audits have to be done at the same time with different teams and probably different partners. So I'm not convinced at the moment, but we'll see what Health Trust Europe come up with. We'll see what they contribute to the process. I've got nothing else to add to my email that I shared with everybody else. I'll take a question, which I probably won't be able to answer, and Kim or Robert may wish to add something.
Okay, Mike, thank you very much. So that's really for information at this stage, isn't it? So has anybody got an observation or question for Mike before we move on? Okay, Mike, thank you very much for raising that. And so that's our assurance section completed, and we'll move on to section 7, which is reports from representatives on projects and groups. So I think you're dominating this little section here, Mike. So we're with you again. We're on the Community Diagnostic Centre project.
Yeah, I do apologise for all this input. I'm in sunny Devon at the moment, which is lovely. I can see the sun streaming in the window over my right shoulder, which is rather nice. CDC, there's been a problem with the steel delivery, as I set out in the report. It was likely to be 4 weeks late. The contractors have reduced that to 3 weeks, and the completion date is now forecast at the 6th of June. it all seems to be going quite well. Apart from that, the construction site looks quite tidy. The scheme looks as if it's going along quite well. There will be a report shortly, I suspect, on the proposals for the health and wellbeing hub. That's being costed at the moment to see if it fits the budget. And I think that's about it really at the moment. It seems to be going quite well apart from the 3-week delay. Oh, the project team are going to look at whether some of the respiratory tests that were promised for March can be delivered elsewhere on the Stratford site or some other way in order to keep NHSE happy, although the NHSE representative at the last project board didn't seem too unhappy about the delays. We'll see. He doesn't seem to be asking for his £8 million back or whatever it is.
Well, we're pleased to hear that. So, okay, Mike, thank you for your help there. Any questions or perspectives for Mike? Okay, so let's move on then to Graham Nuttall and the Elective Hub project. Is Graham with us, Sue? Or
no, sorry, Simon. He sent his apologies.
Oh, okay. So
take the report as read.
We'll take the report as read. So, and we're happy to take any questions if you've taken as read, and we'll see if we can answer them. Otherwise, we'll move on to Ellen Badger and Mike. Roger.
My only comment was to ask for the time-lapse photographs, which I presume are still being taken, to become more visible on the website. We had a link last time which got us there, but if you try to go to the website without the link, it didn't seem particularly easy to find.
Okay, thank you for that, Roger. Adam, do you want to pick on that or pick up on that?
Yeah, I'll pick that up with comms, Roger, and get it a bit more visible. But for those who haven't been to the Warwick site recently, the Elective Hub currently has 2 stories already, and will have its 3rd story in a matter of weeks. So work is going really well there.
It is quite mind-boggling when you see what's going on there at the moment. Actually, very impressive stuff. Yeah, Kim says, come to her office because there's a good view from her office. So Ellen Badger then and Mike Wells.
Thanks, Simon. So I'll take the report itself as read. We had a project board yesterday where everything's still on track, no date changes. It's now a sealed unit. We've decided to take partners round. So Town Council went round a week ago today, and it's raining as heavily now in Shipston as it was when they went round. The Stour Health Wellbeing Partnership have been round and continue to work with us on the health and wellbeing suite on the ground floor. And I think Fiona is going to get an invite to their community hub to go and see what because that's currently taking place in the Scout Hut, and then that will be moving in there hopefully once we open. And hopefully soon, within the next month, the list of services should be fairly locked down and the schedule of clinics. Happy to take questions.
Super. Mike, thank you very much. Sue Warner.
Yes, thank you. I wondered if there's any more news about the community inpatient beds or the and where they may be in the future. There's just some staff that transferred from Ellen Badger who are beginning to ask about what their future holds.
Okay, Adam, I think you're putting your hand up to respond to that.
Yeah, I can respond to that. So it has been a bit of an unfortunately drawn out process, Sue. Governors will be aware we submitted our case, if you like, to the ICB in March 2023, which put the ball in their court for the next steps, and they've been discussing the next steps for a while now, and have developed a pre-consultation business case to go out to a full public consultation on the next steps. That went to HOSC just last week, I think it was, or the week before. And so it looks like there will be, subject to NHSE approval, there will be a 6-week consultation period on the future options for the beds. Now, in the current plan, that will end around about the start of next financial year. But that is obviously subject to the process and NHSC approval and so on, and what happens next. So we are some way off a final decision on that, unfortunately.
Yeah, I wonder if I could ask then, the question that was raised was that the staff were transferred to Leamington to the rehab unit, or a ward in the hospital, and their mileage was protected until the outcome of the report. So can we be assured that will continue until that time, because they've come with outside the actual normal time span?
Yes, we'll continue to protect that during this period of uncertainty, and clearly we appreciate the impact the uncertainty is having on those staff.
Thank you, Adam.
Okay, Sue, thank you for raising that. Thank you, Adam, for your response. I don't think, Sue, we have Michael Coper with us, do we? So
yes, he is here.
Yes, we do.
Well, you're not. I don't know why you're not on my list, Michael. So I apologise for that. So end of life then, Michael.
Well, I'm happy to report on, as an observer on what is a professional committee. So I watch what's happening rather than be involved in any great extent. I'm very proud to do so because, as members will see from the two reports, there's a continuing process of improving and enlarging the end-of-life process at Swift. It is a terribly important issue because whilst we're in the business of getting people well, inevitably people die in the hospital or following on their attendance. And I would draw members' attention, for instance, to the story of the family who were accommodated in ITU in the final days, including welcoming the family there and even having a small party, because that's what the lady wished and they had room. I was tremendously impressed by the effort made by various members of the hospital to bring that lady's life to a conclusion in as happy a way as was possible. I think the other item I would draw members' attention to is the St Christopher's Hospice care programme. It's a training programme which they developed, which has now been taken on by Myton Hospice. But more important, 12 of our nurses have also undergone that training and are introducing that into the hospital. I mention those two matters because there is a very active committee here, or a group of professionals who are trying to improve a very important aspect of the health service. And I would ask other members to support that in any way they can on any other committee that is going.
Michael, thank you very much indeed for that. So any questions or perspectives for Michael? Callie.
Yeah, thanks, Michael. Just a couple of things really from your report. Yeah, they're all doing loads of good work. Anyway, one question is that the supportive and palliative care indicators tool cannot be completed. I don't know if that's to be completed on a monthly basis because of work pressures or whatever. Are the staff aimed to do so? How often do they need to complete this tool? How do they deal with the outcomes of whatever they find out by using the tool? That's one question. The other question is about the National Audit of Care at the End of Life, which involves relatives. And obviously, whoever is leading on this audit apparently has a problem, but it doesn't specify if they try to contact relatives in respect to bereavement or the relatives did not come back to them. I'll try to look into that seriously because it personally involves me, but I just wonder what that means, that they have difficulty obtaining relatives to undertake a survey. because that is very important when it comes to end-of-life care and involving relatives. So these are my questions, really. That's all. Thank you.
As you will appreciate, Callie, I'm an observer, not an expert.
Okay.
It is very much a professional committee, and I do observe it. It may be that Fiona can help.
I think Fiona Michael's just coming in to your rescue on this one. So, Fiona.
Thank you. Callie, I caught the last of your questions, but not the first. So I'll answer the last first, and then if you could repeat the first element.
Okay.
So the after death survey, relative survey of their experience has been undertaken for a number of years, actually in the acute hospitals, but has more recently been extended to community. The process in the hospital is that the bereavement team, when they meet every family after a bereavement, offer the survey to them. I think in the community, it's a cohort of patients that die. Obviously, there's more death in the community than there is in the hospital. And I think my understanding is that they choose a period of time, say 3 months, where they offer it to every relative that's been bereaved in that quarter, and then repeat it at another period of time. So it's not all deaths that are offered that. Obviously, we make it clear to people that we've got the PALS and we've got the complaints and patient experience team, that they can offer patient experience information or raise concerns or share good practice throughout the year. But this survey is a time-specific nature in the community.
Okay, thank you, Fiona. And Callie, what was your first one?
The
briefly?
first question was about supportive and palliative care indicators tool, which is to be completed. It's a document. I don't know if only A&E clinicians are supposed to complete that, or other clinicians as well.
Yes, I think
that.
Yeah.
Fiona. Yeah.
So it is a tool that's been included in the clerking document, with a document that all patients have on admission in the acute medical unit. The doctors have had a degree of training, but I think there is a realisation through the committee that process hasn't been fully embedded. So they are doing some further improvement work, education, training, and liaison with GPs, because your point in terms of that feedback on discharge to the people that are receiving the patient when they're discharged, and what actions need to be taken around a SPIC positive patient is important. So I agree with you. We've still got some work to do on that.
Fiona. Okay, thank you. And thank you, Callie, for your question. Mary.
Yes, I just wanted to comment that Dr. Ketholder did a presentation for governors last week, and it was very, very, very good. She said that the very impressive work that she's doing, so I concur with what Michael said. My question was about prescribing of oxygen. Do they mean prescribing, there's a problem with the doctors prescribing it, or is prescribing being used in the sense of being delivered to patients? Where is the problem there? Is it with the contractor that delivers the oxygen, or is it with the doctors prescribing it, I wonder?
I can help with this one, Mary. I assume, and I wasn't at the last committee where this was discussed, but I'm assuming it's the prescribing of oxygen by the doctors.
So it's an in-house issue with the doctors. Okay.
I believe so, yeah.
As I understood it, it was making sure that people had it when they left and it was available, which they wanted to ensure happened.
Okay.
Perhaps it's timely prescribing so that it can actually get delivered. That might be the...
Yeah, I'll double check, Mary, and I'll come back to you.
Fiona, thank you very much. Thank you, Mary. And John Egan.
Yes, I'm concerned with the relationship between the hospital and the hospices. Only half the patients who request to end their lives in the hospice actually get there, because there isn't really the capacity in the hospice, nor does there seem to be the urge to pass them on. So I'm just concerned about the relationship and how close that is with the local Myton hospice.
Okay, so Fiona or Adam, are you able to answer that?
I think yes, I'll take it unless Adam wants to add something afterwards. The relationship is good, particularly with the clinical teams that work at the hospice and in the hospital. They have a daily call between the two teams that talks about each patient that is on that list. I think, as you alluded to, it is often about capacity and that either the bed availability or the staff availability at Myton Hospice. They have had a considerable issue with recruitment and retention of staff. In order to try and mitigate that, we've recently run a joint training course that was a weeks-long training course for 12 individuals, and we're intending to repeat that from Warwick Hospital. They were fairly junior nurses, but also medics as well, to encourage them to understand the care that is delivered at Myton and replicate that really within Warwick or in a patient's own home. So obviously a bed is a bed in Myton, but we also are encouraging hospice at home models and district nursing provision for people to die at home is good, and we just need the expertise from Myton to help us to deliver that. So I would say the relationships are good, but the constraint is the bed capacity and staffing at Myton often.
Fiona, thank you very much indeed. Okay, so shall we move on? Thank you, and thank you for your question, John. So shall we move on to medication safety and optimization committee, Mary?
Sorry, Simon. I just have a very quick question for Michael. That's all. Who is a contact person for end-of-life care champions? How do you get involved if you want to get involved? Because obviously there is a network locally. I believe it's across the board, not only South Warwickshire. That's all. That's my question.
So I would encourage you to contact the palliative care nurse in Warwick Hospital, and I will remember her name in a moment, and I'll put it in the chat because I can't remember.
Yeah, that's great, Fiona. Thank you.
Okay.
Thank you, Fiona.
Okay, Mary.
Yeah, okay. Medicine Safety and Oversight Committee. There's been 3 meetings since the last Council of Governors. Unfortunately, I missed one because of holiday, but I'll report on the 2 that I did attend very briefly. I report fully each month to the Patient Care Committee, so I will just pick out a few key points.
Okay.
At every meeting, they look at the number and trend of incidents relating to medicines and also now medical devices. And there's a lengthy discussion on the more significant serious incidents. The highest number of incidents currently relates to the administration phase of medicines management. But good news is that the incidents relating to the EPMA have reduced dramatically. One of the meetings I attended, there were absolutely no reports at all. There's a shortage of pharmacists to cover the wards regularly and was considered to be an issue around some of the medication issues, but hopefully these are being resolved following successful recruitment of some pharmacists who are currently starting, I understand, and in a training up process. Each meeting has relevant alerts and they discuss the implications and actions of these alerts. An issue which was mentioned on the Clinical Governance Committee was medicines shortages. This has increased significantly over recent times and takes a lot of pharmacy time to source alternatives and to educate prescribing staff as to what to do. There's a dangerous goods and waste audit being undertaken. There's a regular controlled drugs report from the sent to the local intelligence network from the accountable officer, the head of pharmacy, and she gave a very assuring report on that. And the last comment I want to make is that the ward controlled drug audits have greatly improved. In fact, they're the best they've ever been, following the dedicated pharmacy technician time that's been given to each ward to support the staff. The next step is to follow this work to look how we can get general improvement on medicine storage. That's all I want to say. I don't know whether Fiona's got any comments she wants to add at all.
And Mary, thank you very much. Fiona, anything you would like to add? No, that's fine, thank you. So any questions for Mary? Okay, Mary, thank you for your support there. Thank you very much. Then we're on to Pat Scott and the outpatient letter review. Pat.
Right, very briefly, having undertaken a similar role for George Eliot Hospital, I agreed to be the governor representative on the group looking at reviewing outpatient letters. The meetings were scheduled for Wednesday afternoons. For 3 weeks, I kept Wednesday afternoons free, but no meeting invites were received. As the request came via Verity, I made her aware of this. Eventually, she was able to ascertain that, due to holidays, the meetings would restart in September. She has now been informed that, as the initial template has been agreed, it was felt unnecessary to have such a large group and a governor representative was no longer required. So my thanks to Verity for all her efforts. Thank you.
Okay, Pat, thank you for that update. Okay, thank you for that. Adam, is there anything you just want to add to what Pat has received on that?
No, I wasn't actually aware of that, Pat, but I will pick that up with the team because I do think it would be good to have a bit of governor oversight of our letters. There is more work to do next year as we move to the Cerner system, and I think we do have to consolidate some of our letter templates, and certainly some of the complaints I've received have related to letters. So I will pick that up and maybe have another conversation with you, Pat.
Okay, thank you. I'm happy to go with it if it happens.
Thank you, Pat, and thank you, Adam. So with that moves us on to item 7.8, which is the patient experience group. And Sue, I can't see Sharon as an attendee. I think she sent her apologies. So is anybody else?
Yes.
Is somebody picking this up? Do you know, Sue, or should we move on to the next item?
No, if we take it as read, if there are any questions, we can feed those back to Sharon.
Okay, Sue, thank you very much. So any questions regarding patient experience? Okay, thank you. So we're back with you in that case, Pat, on the patient portal public engagement forum.
Right, well, there's nothing to report because there's been no meeting since prior to the last Council of Governors, but the next meeting is due to take place on Wednesday, 10:30, the 19th of February.
Okay, Pat, thank you very much. So that then moves us on to Patient Safety Surveillance Committee and Carolyn.
Yes, thank you. Sorry, I've got a bit of a throat, so you'll have to forgive me. This was my first attendance, so I may not have picked up everything that was really relevant, but you see my short report there. Maybe next time, once I get more used to the what is talked about, I'll be able to make a further report. I just want to say that the acronyms were manyfold, and I've tried to work some of them out. I don't know that I can answer questions, but if there are, I can obviously pass them on. The next report, the next meeting is on the 7th of October. Hopefully I'll be a little more au fait with it by then.
Okay, Caroline, that's great. Yeah, the acronyms are manifest in the NHS for sure. So let's move on in that case to Radiation Protection Committee, and that's still with you, I think, Caroline.
Well, it is and it isn't. I'm the lead observing governor, but I wasn't able to attend. Callie attended on my behalf, and I know that she's in the meeting, so maybe she can expand on her report. Sorry about the throat.
I hope it gets better. So, Callie, can you expand or are capable of expanding?
To be honest, because I did send a I was chasing, that's why I know we cannot include in-depth reports and audits, etc. But I felt assured when I attended the meeting and the way everyone was engaging and reporting and being enthusiastic in taking forward action points, all that sort of thing that takes place in the meeting. It was my first meeting, and that's why I made these 3 key points that Caroline included in the report. These were my key bullet points from attending the meeting. I did receive some audits and reports after the deadline that we had to submit to whatever this group, I believe, I can't remember, because we had deadlines to submit to the COG, etc. But overall, I felt quite assured, and there is ongoing work taking place, and the usual issues with liaising with different departments and groups within and outside the trust, which is an issue, but they're working on that. I don't have anything else to add, really. That's all.
Callie, thank you. So thank you very much for that, Callie. So I think Fiona and then Adam, you had some observations to make.
Just before they come in, the next meeting's on the 4th of November, and that's in my diary to attend. It's every quarter.
Okay.
Thank you.
Okay, thank you.
Adam and I were probably going to say the same thing if I am a betting woman, and that is that we've had last week we had a announced CQC inspection of the radiation regulations called IRMER, IRMER, and the initial feedback from the team that were involved was that that was a positive inspection. We are expecting a draft report to be sent to us within 2 weeks of that inspection date. So we will obviously share that with the board and the public when we've got it, when it's available.
Okay. Fiona, your bet was right because Adam's put his hand straight down. There you are. So, okay, so let's move on then to Jean Arrowsmith and Safer Discharge Group. Jean.
Thank you. Can you hear me? Because it's been playing up.
We can hear you fine, Jean.
Oh,
yeah.
That's brilliant. Thank you. Right. For the since COVID, we've had lots of difficulties, and Mary's already referred to some of them in terms of pharmacy. But I'm pleased to say that everything I've got to report this time is all excellent and going in the right direction. So the first thing is Anne Hutton has drawn up a strategic operational plan, which has been out to everybody and been reviewed and has been accepted. It was the second time around, has been accepted, and so that's going ahead. CQC acknowledged that Swift, in terms of out of hours delivery, which is amazing, the amount of effort we've put into it in terms of out of hours delivery of TTOs when they weren't ready or the patient didn't take them. I'm being really brief because there's quite a lot. The Water Board was focused on medicines, and again, lots of positive feedback. NHS pharmacy staff, all sorts of things, the technician on the wards, etc., etc. It's been really difficult for the pharmacy staff and the ward staff and of course the patients. But we're pleased to announce that we've had successful recruitment. They are with us as we speak. They're being trained and should be ready by December. In the meantime, it's still on the risk register in terms of not having them available, even though we've got them. So they will be, with that one. Next one is the technician ward base is still under consideration, and it's something I really fought for. And it's likely, in my estimation, it's likely to happen once we've got everybody on board after December. It really will help the ward staff. It will make a difference to patients having their TTOs and having their assessments. I know when I was in recently, certainly felt like I had a pharmacy person all to myself. She spent about half an hour with me. going through all my drugs and checking what they needed to provide that I might not have. Actually, I had everything. So really, honestly, the hard work that Anne and the team and everybody have put in has been excellent. The delivery of TTOs has been really difficult, out of hours TTOs, patients who, when they weren't ready, I mean, if you suddenly ring up your relatives and they said, well, come now, they're not really going to be ready. So in terms of that, we've now putting a much bigger emphasis on making sure that the TTOs are ready for patients when they go out, as if, you know, everybody hasn't got enough to do, but it's really important. So they're really all pulling out the stops to do that. But as well as that, we've now got blood bikers. The blood bikers are taken over from the voluntary team that we used to have. It just became unmanageable. Poor Julie, who we should say a big thank you to, was having to organise all the volunteers. And it took up all their weekend. I mean, they didn't have weekends for months and months. So that's now been taken over by the blood bikers. Funny phrase, and they will deliver day or night. Not that the patients would want them late in the evening, because usually if they're poorly and elderly, they've already been tucked into bed. But yes, that's a real step forward in terms of the way we, or not a step forward, it's a different route in the way we manage. So the wards are really, as I said, pulling the stops and making sure the tablets and everything are ready. The emphasis, so an updated pre-pack, I assume it means that all the drugs and everything that they need are ready. Fiona will tell me, but to me, pre-pack means it's ready. Some of the wards are very used to giving out a pre-pack and having it ready. Other wards need a little bit more support to have confidence building, and that they're not yet doing it to the extent that it would be really useful to do. When the blood bikers go out, they have to get a form signed so that it verifies that they have delivered them, and then they have to make sure that they take them back to the ward, so the ward have got proof that the drugs have actually been accepted and been delivered. We also have, when it's in hours, but the patient's gone home, we also have the facility to take the drugs to the telephone room, and they can be left there for the relatives or somebody to collect them. In terms of criteria-led, I'm sorry, but I'm pleased, criteria-led discharge varies from ward to ward. Some wards are very used to having criteria. It means that you've got everything ready and you put it ready before you've even decided that they're going home. They sort it all out in readiness. So that needs a bit more emphasis and a bit more confidence building. They're also looking at, which we've talked about quite a lot, the difficulty in having a discharge checklist is with the patients who are what I call out of town. They're patients from other than Warwickshire. And so it's difficult to actually tick all the boxes that you've organised everything if you're not quite sure yet that you have. But in terms of a respect form, it's really important that you have a tick list so that we can guarantee and know with confidence that the patient has been given a respect form. I've nearly finished, sorry, honestly. I think that's about it. There's lots of discussions and lots of really positive work going on, and I think the wards and the pharmacy staff and everybody should be really, say big thank you, and thank you to the bikers. I don't know if Fiona wanted to add to anything. It's quite a lot to go through very quickly, which is why I didn't do a write-up. I thought you'll be reading pages.
Thank you very much. We could feel the positive vibes coming through there. So. Is there anything you want to add, Fiona?
No, that was a comprehensive overview.
Yes.
Okay, so Mary, then Callie, and then I'm just conscious we need to keep the pace going, so we'll move on from there. No, don't be sorry, Jean, at all. Mary.
Yeah, I mean, in chatting with Julie about her voluntary service that they used to run, she raised an issue about the fact that they used to take equipment as well. And I don't think the bikers will be able to carry the equipment. Is there any facility for delivering sort of equipment out of hours?
Shall I answer? That wasn't brought up in the discussion, although we have talked about it in various meetings. It didn't seem to be a very high level issue to the nurses who were managing the meeting. So I will ask about it though, Mary, at the next meeting. The meetings are every other month. Yeah.
I think Fiona's coming in to answer that with a... Okay.
Yeah, so my understanding, Callie, is that it will be the logistics team run by the estates team at Warwick Hospital. So they have a van and can do equipment delivery.
Okay, thank you.
All right.
Thank you, everybody, for that one. And then finally, Callie, before we move on.
Yeah. Thanks. I just I did ask that in the past. Anyway. With this group, I just wanted to know if there've been any audit regarding safe discharges. You mentioned the criteria for safe discharges. Is it the same criteria that apply to all wards and all patients? Because obviously patients have different conditions, they're discharged for different wards, etc., etc. I haven't looked into detail into the criteria, but I just wonder if the criteria are the same across patient groups, across wards. And when it comes to discharges, is there a template? Is there a checklist? And what sort of information clinicians are using? That's one question. The other is if there've been any audits. And that's it.
Hold on a second. Hold on one moment. So Fiona, can you answer that question for Callie? I think you've come into.
Yeah, there is a standard discharge checklist for all patients.
Okay, thank you. Okay,
and the CQC actually congratulated us on it and our use of it.
Right.
Okay, thank you, Jean. So, and your last question, Callie?
If there've been any audits on safe discharges, I know they do audits now and then, but or they intend to do one in the future. That's all, across the trust or different wards, etc. That's all.
So the safe discharge group has a information pack which is uses complaints and incidents data and patient forum feedback or governor feedback as a way of triangulating the safety. But they have done audits of the discharge checklist as part of our care indicators on an ongoing basis as well.
And the new standard operating procedure was seen as a big part of making sure that the evaluation is built into the everyday. That was actually quite a huge piece of work. So thank you to Anne Hutton for initiating it.
Thank you. Thank you, Fiona. And let's move on now then to John Egan and the Salix Project Board. John.
This is a very sensible project which appears to be under control. However, I've been trying to visit the project for some time, and each time I've made an appointment, it's been cancelled. But that's now been broken up by my holidays and the fact that my office is burnt down. So in amongst all this, I would like to visit the project because you really can't understand this very complex project without actually seeing it all. So I keep trying to visit, but I'm afraid my visits have been cancelled each time I've organised it. So I'm sure we'll be able to get a proper visit, but I can't properly report on it without seeing it all.
I understand. Yeah. Okay, John, thank you. We'll look in the background about making sure you do get a chance to visit.
Thanks.
Adam's just nodded to say he'll pick that up. So, John Holland.
Yes, I've just put my hand up because I have managed to visit. John Egan and I have been attending meetings with the staff, and it's a very impressive project, retrofitting carbon zero heating to buildings built over a number of different years is not easy or straightforward, but the Welsh contractor specialises in this. Workmen are living in the area while the project is underway, and I was very, very impressed, I have to say, at what's going on. I also had the opportunity of talking to some Welsh people about how they get on with their 20-mile-an-hour speed limit in Welsh towns. And they say it's actually been very, very effective at reducing collisions and casualties. The reason it's being criticised is there's too many changes of speed limit too quickly. So, you know, in 100 yards, you can have a 20, 30, 50-mile-an-hour speed limit, and they need to have fewer changes, and then they'll get over their problems. So it's interesting what you learn when you talk to people.
It certainly is. Okay, John, thank you very much indeed for coming in there. So let's move on then. I'm conscious we're slipping quite a way behind here at the moment. So the Serious Incident Review Group, and Callie.
Right, yeah, thank you. Again, that's that's a group where like the radiation group, that we can share that much information when it comes to audit reports, whatever action plans, because of their confidentiality, etc., etc. And so I attended 3 meetings, May, June, and July. Yeah, I'm fully assured, and Fiona is here, that everything is in hand as per my brief summary. Yeah, the procedures are followed, investigations are thorough, and action plans as well. I know there are always issues when third parties are involved, but the trust officers are doing a good job in chasing all these issues, because obviously when it comes to other trusts and other organizations, it's quite difficult to sort of meet targets and timescales and etc., etc. But all the trust officers are doing a good job in chasing all these issues. That's all I remember from these meetings. And people do have their reports on time when they're asked to. I noticed that from the meetings. So overall, I'm pretty happy with what's happening in this group, and it's positive vibes. Thank you.
Thank you, Callie. That's great. Any questions or perspectives for Callie? No? Okay. And then that moves us on to nothing to report on wayfinding. So it moves us on to a Quality Delivery System Framework Group and Jane Knight.
Did you say Jane Knight?
Yeah,
sorry.
That's okay. It's all right.
What am I supposed to report on?
So you're on the Equality Delivery System Framework Group.
Sorry, I'd forgotten. I was told to report that it hasn't started yet.
Oh, okay. Right.
But we're about to, so maybe have something to say next time. Sorry, I got lost there.
Don't worry. Thank you, Jane. Let's go on then to Mike Wells and Governors Election and Induction Working Group. Mike.
Thanks, Simon. Yeah, so this is a new group. It's we've got elections in the new year. So we've had our first meeting, been through all the materials, identifying what needs refreshing. Big thanks to Sarah Collett for bringing everything up to scratch. So just for the public's awareness, nominations are open and have to be in by the 13th of December. Voting's 21st of Jan to 13th of February, with the results on Valentine's Day. And then we'll have a face-to-face induction in March, followed by a COG, which gets everyone in place.
Right.
What I would like to say as well is I'm agenda item 17 in section 7. So that just shows how many of the governors are really actively involved in participating in all the activities across the trust. It's very impressive.
It is. I was going to make exactly that point as well, which is really, it is very impressive, isn't it? So, and thank you all for your involvement. So, Pat Scott, you've got a question on perspective.
I've just got a quick question, actually, because now since COVID, with meetings now on Teams, are we precluding members of the public standing for election as they do not have the access to the essential technology?
Right.
That is my question. Sorry.
Okay, well, I think that's a very left field question. I can see from Mike's face he doesn't know the answer to that, and I'm not sure I do either.
I don't know, to be honest.
So I think you better leave that with us, Pat, and we'll suck on our teeth and work out what we need to do if there are things we need to do to address that point. Yep, Mike, can I leave that with you and we'll pick it up? Yep, thank you for the question.
Indeed. Thanks, Pat.
Bamboozled everybody with that one, I think. So that moves us on then to item 8, which is governance matters. And we're sticking with you, Mike, on general purposes committee.
Thanks, Simon. I'll just take this report as read. The governors get to see the outputs through the agendas, through the training sessions. So yeah, I'll just take any questions.
Okay, any questions for Mike? Okay, thank you. Just before I move on, Roger put something, wayfinding strategy group meeting is out of schedule with council. Oh, okay, so we need to just try and get it synced more in with the meetings, is the observation, Roger. Yeah. So Sue, can we just pick up Roger's point if you don't mind?
Yes, we'll do.
Okay, so 8.2 then is the patient care committee minutes for 5 meetings. Andy Petros.
Simon, I don't believe that Andy has joined us.
Okay, so we'll take that as read. So has anybody got any queries or observations regarding those? Okay, that moves us on then to Mike Flaxman with the membership and engagement committee update. Mike.
Hi, Simon. I've got nothing to add to what is probably my final report on this meeting. You'll note my resignation at the end of it, and the future of this committee will be discussed at General Purposes Committee on the 10th of October.
Thank you, Mike, and thank you for your work on the committee. So that moves us on then to you, Sue, on patient and public engagement update. Sue Bunn.
Thank you, Simon. So this is just providing some background information about the patient and public engagement strategy that Mike has referred to in his report. Ellie Ward has been tasked with overseeing this piece of work, and the first draft of the proposed strategy will hopefully be ready by the end of this month. My report also covers an update from the latest online clinical wellbeing session, which was held on the 17th of September, a dementia awareness session, and the report also covers the future topics that we will be planning for future online sessions. Thank you.
Thank you, Sue. Any questions or perspectives for Sue? Okay, and then we're still with you, Sue, on 8.4, report on resignation, appointment and election of governors.
Yes, very brief. There have been no resignations or appointments since the last COG on the 9th of May, and the report also sets out the timetable for the governor elections, which Mike Wells has just referred to in his report. Nothing further to add.
Lovely, thank you, Sue. And then we're on to the external auditors annual report, and we don't have a representative, I think, Sue, from the external audit.
Ben Sheriff is here from Deloitte.
Sorry, Ben.
So, thank you. I've been sitting quietly.
Okay, sorry, Ben. Over to you.
No, not at all. So our report summarises our work over the year, looking both at the Trust's financial statements and its arrangements for using resources with economy, efficiency, and effectiveness. So the value for money responsibility of what we look at. From the financial statement point of view, the main areas we focused on were around, so the significant risks for our work were accounting for capital expenditure, looking at completeness of accruals, provisions and related expenditure, your property valuations, and management override of controls, which is a required risk under the auditing standards. I'm pleased to confirm we issued an unmodified opinion on the Trust's financial statements, meaning that in our opinion the financial statements gave a true and fair view of the Trust's financial position. The The bulk of the report is on what we did on the Trust's arrangements for securing value for money, so how it plans and manages its resources, makes informed decisions, manages risks, and uses information to improve its services. The 3 areas we look at that under: financial sustainability, where we've highlighted a number of challenges in the health economy generally, and in particular when we looked at the Trust's position that it had reliance on non-recurrent savings, which just increases the risk of achieving that financial balance in future years. However, we concluded that the Trust's arrangements were appropriate. The other areas we look at are governance and improving economy efficiency and effectiveness, where we didn't have any issues highlighted, but we had a small number of recommendations we've made towards the end of the report. Very welcome to take any questions.
Okay, thank you, Ben. So any questions or perspectives for Ben? Mike Flaxman.
I was interested in the comment on page 198 about the Trust improving its data collection and analysis to focus on health inequalities, which of course is I think objective 8 on the Trust's list of priorities at the moment. I was just interested in seeing that and your recommendation that the Trust should consider how additional analysis and reporting should be considered in the Trust governance processes. I don't know whether Adam wants to comment on that.
If I maybe contextualise it for a moment while he thinks whether to respond. And this is something we observed at a reasonable number of trusts this year. This is a new requirement NHS England had to report and comment in a particular way. I think quite a few trusts had things that they were doing about health inequalities, but those things didn't quite line up to the ask from NHS England. So there were some gaps in what people were able to say or report, and perhaps reflecting a national picture rather than what had been a local focus on certain things. But Manager, I'm sure, will comment further.
Yeah, we had a good presentation at a training session on Objective 8 from the from the public health linked part of the organisation, and I thought that was quite useful, but clearly we need to do more. Thank you.
Adam, you got to.
Yeah, happy to come in. I think we are doing a lot in this area. We're particularly doing a lot with data and the analysis of data. I think what we need to perhaps do more on is I'll call it the so what. So taking the data and what's the next step? How do we transform? How do we adapt? How do we respond to it? And that will be a real focus for the coming year.
Okay, thank you, Adam. Roger.
Merely a comment, I think, for the auditor. There seems to be an awful lot of changes in audit requirements and the specific items that need to be covered in the audit that has just finished. Do you anticipate a significant change in the requirement rules for the current financial year, or do you think there will be stability in the requirements for at least 1 year?
So the general scope of requirements is reasonably stable this year. In your annual report, you have the next phase of the Task Force on Climate-related Financial Disclosures, so sustainability disclosures. You've got more that you'll need to include there, but we don't have a responsibility for auditing those disclosures. We just need to read them, and I'm sure we'll have some discussion about consistency of what they're saying to what we understand from the rest of the Trust's arrangements. But the general scope of the audit's relatively stable. From outside factors. From inside factors, clearly you've got your EPR project and some big capital works underway this year that have been mentioned, and those are going to be things we're going to have to look at. And also you'll see a transaction of the property, and all those are things that are different this year.
Okay, Ben, thank you. And thank you, Roger, for your question. So last two questions and then we'll move on. So Kim and then Jean.
Sorry, it wasn't a question. I was going to respond really, I think, just to, I think Adam's already responded about health inequality. So just give assurance really that we are working with the system around health inequalities. There's a group really looking at how we link in with that work at system level and how we, work on the matrix review meetings to look at it. So just to give governors really assurance that work is underway, and also the work that Ben's referred to around carbonisation. Clearly, these are recommendations that we will pick up and work through, and the bigger issues that we've dealt with the trust around the EPR and the significant transaction, we are engaged with the audit with the auditors around our accounting treatment, and those reports will be fed through our audit committee, so they are on the agenda as well. So just to give you again assurance really that there is oversight around those pieces of work.
Okay, Kim, thank you very much indeed for that. And Jean.
Just to say, we must be very careful when we talk about health inequalities. It's necessary to do what we've done in terms of the report you're talking about, but the number of people who are helped by our community nurses, by, if we use an example, the fire service, which we enable, which we ask them to call, which Warwickshire County Council pay for, the prevention team, they take people home, but they go in the houses and they use place to refer them to so many people, because they're very often the elderly or neglected people who never let anybody in their homes and don't see anybody. And the extreme health inequalities need, or poverty need, or whatever you want to call it, they're not all poor. It is enormous, and we make a massive difference. And everybody forgets because they do the normal traditional reports. And I led on health inequalities in Coventry for 10 years before public health came back doing reports and things, with a team of 28 by the end. And we made such a difference to people's lives and improved health inequalities. So we must be really careful when we think about the word health inequalities and we talk about these reports, because it doesn't sit very prettily in the way we approach them at the moment. And we should be more aware of what our community nurses and other place especially are doing, and everybody's playing their part. I'll shut up, but it's something I feel passionate about if we actually want to make a difference to people coming back into hospital. Thank you.
Jean, thank you for that. Thank you. So, and Ben, thank you very much for your report. So that moves us on to the last item on membership and engagement, which is back with you, Sue, on code of conduct for governors.
Thank you, Simon. So the Trust Secretary carried out a review of the Code of Conduct ahead of an item being taken to the last General Purposes Committee meeting. And as part of that review, she identified that the Trust standing orders referred to the Code of Conduct for Governors being reviewed annually, but the Code of Conduct stated a review every 3 years. So this was highlighted to the General Purposes Committee when they undertook a detailed review at the meeting on the 11th of July. There were some proposed amendments to the Code of Conduct that have also been put forward, which are shown as track changes in the attached document, and the Council of Governors are asked to approve the Code of Conduct. Thank you.
Okay, thank you. So, Mary, before I make sure we get an approval for Sue, Mary.
Yes, at the induction meeting for new governors that we had, we discussed the equality, diversity and inclusion training, and it was suggested and agreed there that all governors should attend that training as part of their induction, not just those that are they're interviewing. So if we look at training and development on page 8, I just wondered whether the members would agree that we should change that to all governors rather than just members of the Nominations Remunerations Committee. It was thought that it wasn't just an interviewing issue, it was an issue of sort of how you behave in general. I don't know if
Okay.
it's appropriate to take that now, Simon, but I thought.
Okay, so let's take that one now, and then we'll go back and pick up Sue's point as the second point then. So I think Mary's very clear about what she said. If you don't agree with Mary's proposal, please raise your hand. Otherwise, we will change the guidance that all governors get that sort of training. So take your hand down, please, Mary, if you can.
Oh, sorry.
So raise your hand if you don't agree. Are you raising your hand, David, because you don't agree? Okay, that's good. So in that case, we have one who doesn't agree, David, and the rest of us do. So I think that's carried then, Mary. So could you pick that up, Sue? And just remind us again, Sue, what the first point is we're voting on?
We're actually approving the code of conduct subject to that change that we've just agreed.
Okay. Fine. So if you don't approve the change and the new code of conduct as described by Sue, please raise your hand. Okay, that's great. So that's approved, Sue, and thank you for your hard work there.
Thank you.
So any other business? Lovely. Any questions from governors? I think there probably aren't any more. We've had quite a few so far during the day. Oh, there is. Kelly?
Yeah, sorry again. I don't know if I can ask Fiona. There were a couple of things, or anybody else really who attends the patient care committee. I don't know because I forgot to ask them earlier on. Really, there is an ongoing issue about missing stroke data being reported in an integrated performance report. And that is an ongoing issue that apparently been closed at some of these patient care committee meetings. I just wanted to know what's happening with this issue, and that's one of my questions.
I'm not sure we understand what the issue is, Callie.
Yeah, it's in the action plan in most of these patient care committee meetings, and it says that the chair of the patient care committee meeting, which is Dr. Petros, to raise the issue of missing stroke data at the Clinical Governance Committee meeting. And this issue seems to appear on the action plans, but eventually it hasn't been addressed, but it's been closed. That's how I read the minutes, unless if someone else can enlighten me on that. But that is the issue anyway.
All right. Okay, thank you, Callie. So Fiona, I think you're coming in to respond to that, I think.
Yeah, I haven't got the papers in front of me, but as I've just understood, Callie, the action was for it to be raised at clinical governance, and it was. So I suspect that's why it's been closed. David, you may be able to help me out on the conversation we had at clinical governance and how we were taking that forward. But I know it was a question from David G as well as, but David Spraggett and I have discussed it at.
We have indeed. And just for information that, Charles has been quite active in obtaining this information as much as can be from the ICB level. I'm not sure Charles was completely happy with the outcome of his discussions, but I've little doubt he'll have briefed Bhaskar on how to continue that.
Okay.
Obviously, it's been referred to the Integrated Care Board. It's been referred, I believe, to the Integrated Care Board.
Okay. That's correct.
Yeah. Okay. Thank you.
Okay. All right. Thank you. So David, then Jean, and then we'll move on. David.
Thank you. I've been involved in the strokes programme in South Warwickshire for over 20 years now. I can elaborate on this, but not in a public domain.
So, are you happy if Callie wants to talk to you, David?
Yeah, that'd be great. That's great. Thank you.
Thank you, David. Jean.
Just to say, in discussions, I was asked to further my request to the board about getting this information because nobody else including Charles, seemed to be able to get the detailed information. So I wrote to them, no answer, wrote again, got an answer. It wasn't full enough, but it was a little bit helpful. And I wrote again, I haven't had an answer to the last bit. We need to know what's happening to our patients. And it's only a tiny, tiny few who are referred on over the weekends for stroke care to our Birmingham colleagues. And I don't know if it's even relevant. Perhaps they're all happy, but we don't know if they are. David would know. But yes, so it would appear that my work to get some results resulted in, but certainly Charles said what he wanted, he didn't get.
So can you send your last observations, your notes to David Spraggett, Jean? And David, could you just pick it up and...
Will do. Will do.
Lovely. Okay, thank you. So thank you everybody for that. So Sue, do we have any questions from members of the public? I'm not sure if we have any members of the public here today. But...
no, we had no questions submitted.
Okay, right. So thank you, everybody. That's the end of the public meeting. So if we're running 15 minutes behind. So if we come up for air for a couple of minutes and then we'll come back and kick off the confidential meeting in enough time to make a cup of coffee, 2 or 3 minutes. Yep. Okay, thank you.